citizenship. So, for those of you who don't know me, I am Selena Zachman, the Provider Relations Liaison here, and I am going to be the host for today's meeting. So let us just jump right into our agenda. And today we are going to have some staff updates. We are going to hear from our new CEO. We are going to have an update from Dr. LJ Shipley, our Associate Medical Director for Maternal Child Health, on the 1115 waiver and the progress with that initiative. We are going to hear from Elizabeth Sharp, our Director of Clinical Operations and Quality Improvement, to give us some quality program updates. Jana Darlington, our Director of Provider Network Management and Payer Relations, is going to share a new initiative that we are embarking on, the ACO REACH program. Also, we'll review some provider contract timelines, and then we will have some time for open discussion. So here are some of our AHP staff updates. We are going to start off by welcoming back Jana. Jana came back a few weeks ago now, after she welcomed a beautiful baby boy to her family this March. So we are so happy to have you back and to watch this beautiful little man grow and just have your wealth of knowledge and support. So welcome back. We have Tanner Buchanan. He joined AHP's pharmacy team in August. And for some of you, Tanner's face may be familiar. He completed ambulatory care pharmacy residency as well as community pharmacy residency with us. So we are excited to welcome him officially to AHP and excited to see what will come. And last but not least, we are welcoming John Williford, our new CEO. John is a seasoned healthcare executive with more than 20 years of experience leading complex multi-site operations across health systems, managed care organizations. Most recently, he served as Vice President of Population Health for the Montefiore Health System and Chief Operating Officer. Hold on, my screen popped up here. For Montefiore's care management organization. We look forward to his leadership as we continue to build a stronger and more connected system of care for our community. So please, everyone, join me in welcoming John.
So,
So,
Selena,
yes, go ahead.
sorry, I jumped ahead.
No,
So,
you're good.
Selena, thank you, and thank you everybody for the kind words and warm welcome. It is day 8 for me, so I am getting immersed deeply into AHP, into our clinically integrated network. And, I just want to say the staff here is amazing. We do amazing work, and all of our practices and all of the partners in the clinically integrated network have been doing phenomenal things. And so I look forward to working with each of our practices and each of the practice administrators as we move forward and we venture into new programs such as the ACO REACH and other programs as we seek to evolve HP into our next generation. You guys are key to everything we do and are key to the success of our risk bearing arrangements and our quality outcomes. And I have to say, I've been super impressed by the quality performance of the network and how well we perform on quality metrics. So again, I just want to thank everybody for welcoming me. I look forward to working with all of you and continuing and building upon the phenomenal work that each of you guys do every day. So thank you.
Thank you so much, John. So our next agenda item is our SEN update. We are going to turn it over to LJ to lead us off with that. I'm going to stop sharing the screen for just a moment and she will take it from here.
Thank you. Selena, I'm just trying to share my screen and I apologize that it's not letting me do that yet, but I think I was trying too fast. Hold on. There we go. Now it will work. Just let me know if you all can see that in a moment. It's going to do something funny for me, I'm sure.
Yes, it's up there now.
Okay. Can you actually see it as the slide show, or are you seeing?
No, we're
Yeah.
seeing that. Yep, just go from perfect.
Is that working well?
Now
we
it's in
can
presenter. So
Ah!
just,
Display settings?
yep.
Got it. Yay, I'm getting better. I was faster than at the last meeting when I had to do this. Thanks, everybody. Hope you're all doing well today. I just wanted to give you a little bit of an update about where we stand right now in terms of AHP's role in supporting your work with the social care network, supporting your patients and your practice needs. So we have, I'm just going to remind you of where we landed in terms of the options by which practices could participate with AHP support. And just want to highlight again, our goal in this is really about supporting the screening and eligibility determination and the care management where needed. But our ultimate goal is that we really figure out ways to transform the way we address social care needs for our patients. We know it is critical, and it's only becoming, I think that the social care needs are only increasing in our many populations. And if we don't figure out innovative strategies to support practices and tie to community supports, we're going to miss the boat over and over again. And so this is really an opportunity for us to work in this space with you and with other colleagues like FLIPA and community-based organizations. It's also a chance for us to inform New York State. This waiver is a demonstration project of how Medicaid dollars could be used to support screening and connection and care management, but also actually put dollars towards social care services that are required. And so I think we want to be at the table as accountable health partners, but as this network speaking to what we know can work, where we can do better in this space. And so this gives us that opportunity. So I just want to always, whenever you're answering to the tune of a grant or a program where someone else has set the rules and the guidelines, it's really important to stay grounded in the reason we're doing it. So just as a reminder, 3 options. Some of you in your practices have said, we've got this, we're going to do the screening on our own, and we do not require AHP involvement. That's option 1. Option 2 is where there's some shared responsibility, typically where practices have chosen to do the social care needs screening, input that information into the FLIPA platform, which is called Find Help, and then do a warm handoff for support on some of the more time-consuming and also more care management roles that follow that initial screening. And that's where we've been working with a few practices in the option 2 space. The majority of our practices and teams have chosen to go with option 3, which is where AHP becomes the proxy for doing screenings, entering the data, determining eligibility, and managing the care navigation and patient management. And so in that space, I will be very transparent and say this is a constantly shifting landscape, because in the way that the system has been set up, even for our colleagues at FLIPA and across the state, that there are continual changes in some of the rules and requirements and recommendations. I believe that the program booklet is now in iteration 5 in terms of how teams are approaching this work. And so what we wanted to do was be sure we knew a best approach that could meet the needs of as many patients as possible. And at the same time, be very patient-centered. The last thing that people need is for us to be reaching out, asking more questions, and questions that can be very, very personal for folks, and have them feel not supported, overscreened, losing trust in the system of care. So we've done 2 pilots, actually 3 pilots that we're kind of wrapping up with right now to be able to understand the workflows best and optimize the team functions. And for those practices who have participated in those pilots, 2 practices in the option 2 category and 1 practice in the option 3 category, we're really grateful for that, because we've learned a tremendous amount about what is required of our team to understand in the platform and where we can do better in that space. And so what we are at right now is we're wrapping the pilots, and we will begin more broad implementation of this program across our practices starting next month in October. And so one of the things that we've determined makes sense in this space is to really adopt a population health approach. It's not that we don't want to screen every patient, but to literally use an alphabetized list of patients on Medicaid or managed care Medicaid and go through that list, whether or not they've been in for a recent visit to your practice, whether or not they may qualify for these enhanced services doesn't make sense to us. And so we think we can take advantage of all of the strengths that we have in terms of accessibility to data and partnership with your teams, so that we're going to try to prioritize screening patients who do have some of these eligible conditions. So as an example, looking at patients with asthma, who we know already fall into a bucket with a chronic medical condition where there is the opportunity for home environment modifications that could qualify for services under the waiver. Also looking at pregnant and postpartum individuals, because that is a class that requires no other qualification other than being pregnant, postpartum, and being on Medicaid or managed care Medicaid. We're looking at other conditions or populations within our adult space and in pediatrics as well. And that is how we are going to roll this out. What that will allow us to do is actually screen as many patients as we can across the network. So we're hitting a population of patients in all of your practices that are participating with us, and really always adhering to a strength-based, trauma-informed, and family-centered approach. Again, so we're building trust, making connections, not creating more any more sense of what in the world is the health system doing now and why is another person calling me, for our patients and families. The way we're going to do this now, pleased to say that we have a plan in place now to be able to increase our efficiency and staffing, utilizing trained community health workers who have a great knowledge of community resources, have the skill set for connecting with families, and they will be able to articulate with and work with our AHP care management teams so that we can appropriately triage identified social care needs. There will be some things that will raise to the level of our care managers. There will be other things that will be able to connect directly to community-based resources, utilizing both the platform that FLIPA is using, but also through some of our institutional knowledge and expertise about partnering with community organizations and community resources. So I want to leave time for questions. I just wanted to make sure I could level set with this. This is where we are, and communicate very clearly. All practices who have requested either option 2 or 3, who have not been contacted yet, will get a communication from our team by the end of, it says next week. Sorry about that. It's this week. You're going to get a communication by the end of this week. And we will have a plan outlined with you specifically about these initial screenings and navigation. I want to say 2 other things. One is this work will satisfy the PCMH requirement. We understand that that is a very important deliverable for all of you. You are doing the work of being a patient-centered medical home. You deserve to receive that extra reimbursement. This is one of the criteria for receiving it. This will satisfy that. And we will be obviously continuing this work through the duration of the waiver, and I think building on our abilities to partner more closely with you, make sure we really are capturing as many patients as possible as we move into next year. And really thinking about how do we learn from this? What do we structure in terms of what we do going forward? And the one thing I would say to you is in the communication we send to you, we may be there may be a little bit of a tiny survey in that if we need additional information from you about what screening you may already be doing and what screener you may be using in this space. And also what your capacity is within your EMR. If we asked you to pull a patient listing with a particular diagnosis condition, we know some EMRs are very skilled at that, others are not. We will only be asking you what is readily doable in your system, but it could provide us with another source of patient listing that we could work from, but we can pull data from AHP's lists, and that's where we're starting. And for those of you on the call who may be option one, you're going to get a little touch base too. I think it's really important to learn from other people who've been working in the system. Our teams clearly have been doing that, and we've been reaching out to other collaborators through FLIPA outside of AHP to learn their best practices. We'd like to learn yours too and find out if there's anything else that you need in terms of support. So that's what I have. I'm going to stop sharing and just ask if there's any questions. I can't tell if there were questions in the chat.
There is one question in the chat from Jerry at Westside Pediatrics. When will the screening tool be rolled out?
So Jerry, the screening tool, as the way it's been set up from the state, specific screening tool that where the data has to be entered into the SCN platform. So this is not something where there's any interoperability or connectivity right now. I know they've been working on something like that with FLIPA, but in general, working with the Rio and things, but that is a ways away. So the screening tool is online. We've provided it in past communications. If anyone needs for us to pop it back in the chat again, it is the Accountable Health Communities screening tool. It's a CMS tool that is what the state had decided to do. Our hope is in time there will be crosswalks to other screening tools, but that is the one that needs to be used. And in order to partner on this effort, data has to be entered into the platform. It can't live in your practice record, but not be moved over. So we're trying to reduce double documentation. Our community health worker teams and our other operations team within AHP will actually be doing that screener. Much of it will be by phone, but working with you to make facilitated connections to patients with a good script that explains who we are, that we're working with your practice, and making sure that you know when that will start. I don't know if that answered your question, but it's not a matter of when the screener is rolled out. I think we're having to play the game this way because there have not been solutions determined at the level of the state or even within our SCN that would allow us just to pop a screener in over to you and in your record. We've got to make it as efficient as possible. And if anybody else from our team wants to pop in with other answers, please don't hesitate. Thanks, Jerry.
Can I ask a quick question?
Sure, Melissa.
So we are one of the practices that chose option 2 moving forward, and this obviously was before the abuse questions came into play, and kind of knowing how that will fit into our staff ability to adequately screen in the time. Are we able, if we want to move to option 3 at some point? I mean, I'd like certainly to sit down and chat with you about what it looks like to screen with the abuse questions and the practices. But if we feel like we're not able to do that, just wondering if we can then move on to option 3.
Yeah, I think let's talk about that, Melissa. We want to be as flexible as we can. And like I said, we're trying to build our capacity to do more. Yours is not the only practice that has, or system that has asked for this. And that's one of the changes that came along. As the SCN work is unfolded, you raise a really important point that gave all of us pause. The screener went from being, I think, a little more targeted towards social care needs that were housing, food insecurity, transportation, which are still sensitive issues to ask someone, but with the addition and requirement of the safety questions that really are around abuse or safety for an individual, it requires a very efficient, timely, and skilled response. And so making sure that clinical teams are able to respond to that. We are fortunate that we have our care management team who, our social work care management in peds, our nursing and social work care management in the adult space are very skilled at this. But it's one of the things that we've been looking at in terms of who can do this screener, and then what happens if that flag's positive. We have to have a response. It was one of maybe the second or third iteration of change. So yes, Melissa, let's talk.
Thank you.
You bet.
May I ask a question in terms of workflow when you guys are reaching out? Because obviously in pediatrics, one household may have 2, 3, 4,
Yes.
5 children all on Medicaid. And will that be looked at, or is there a possibility that AHP is going to look at that when they call the families, so that the family is not getting, 3, 4 calls, and it could all potentially just be done with one for all family members eligible?
Tanya, I always love your questions and have our team has had that same family-centered focus as we've approached this. I would like to say whenever possible, our teams will be trying to screen at the family. And it probably will be just the children because it might get a little bit more complicated. We will see, but we have tried that in our pilots, specifically the pilot with our pediatric practice that chose option 3 and worked with us. The screenings themselves are not as time consuming as the next step where you navigate and try to determine eligibility. And we have found that can work very well when we can determine, we do have the ability to look in that way. So it may not happen every single time. A parent may not want to sit on the phone for as long as it would take us to do the full complement of children. But I agree with you. The last thing we want is every week I wouldn't pick up the phone. I have to be honest with you. If somebody called me twice, even the month, to do the same thing again. So yeah, we will keep this as family-centered and patient-centered as we can. Thank you for asking that.
Okay, thank you.
You bet. Any other questions? Keep them coming. We really are still trying to figure this out and do the best that we can in this. And so we will be very responsive to your feedback and to your ideas. Thank you. Thanks, Lena.
Thank you, LJ. So next on our agenda is an update from Elizabeth Sharp on our quality program.
Thanks, Selena. Hi, everybody. I'm going to share my screen as well, which should surprise no one. You'll notice today that I have a quality status update, not a quality performance update. And the reason for that, just a quick reminder for folks, for 2025, because we are in the process of still, in the works, but moving towards the completion of our Health Catalyst implementation, we had agreed that our 2025 quality performance was going to be, sorry, can you guys all see my screen? Okay, I don't have a little green thing around it. So
yeah, it looks good.
Good. Oh, good. We had agreed that our 2025 quality performance was going to be based off of our Excellis network-wide performance. And so, though I hate to say it out loud, we were going to be using the Arcadia system for one more year to show folks that performance. We are currently having some data issues in the Excellis Arcadia system that are making it challenging to report out of that system on that network-wide level. We are working with Excellis and Arcadia for a resolution there. Happy to bring that back to folks when we get some additional information. Health Catalyst isn't yet fully implemented across the network, so that network-wide performance is difficult to share, but where it is implemented, the practice performance for our connected practices is ready to go. So with that, what we're looking to do now is start training on our quality dashboard. We've built a dashboard to show practices, providers, whoever's interested, how they are performing to our quality metrics. We are currently scheduling and conducting trainings. We've actually done a couple this week already. The dashboard will be available via the provider engagement report, and you're going to get some outreach about that to you and or your docs coming from Kevin Kelly. So we are reaching out, we are looking to schedule the trainings. And again, the reason for that is we want to be able to surface your data for you. And if your practice is connected to Health Catalyst, which at this point most practices are, we are able to show you that data. The trainings so far have been going well. I'm going to stop sharing. We've gotten some good feedback from practices, and also some good insights into where we might want to be looking to go next. We're starting out by trying to surface what you guys used to be able to see. One of the exciting parts of Health Catalyst is going to be where we get to go next. So certainly more to come on that. And I see the note in the chat from Lisa. Kevin is on this webinar, so I will have him reach out to you via email and we'll work to get something on the calendar. Any other questions?
I do want to jump in quickly just to say in Kevin's outreach, he is asking about users for the PER dashboard and the quality dashboard. And so over the years, as we've transitioned from Arcadia to Health Catalyst, certainly we've seen that some users have, fallen off or are not using the platform. This is a really good time to start thinking about who at your practice or your system you want to kind of be engaging with us in quality and monitoring that performance, so that when Kevin's doing his outreach, we can kind of streamline adding new users, returning users. He does send over who the current users are, so you can review that. But it's a good time to start thinking about that as well, while we're moving to the new platform.
May I ask a question?
I'm sorry. Yes, go ahead.
So I'm confused. So the 2025 quality measures are going to be based on Arcadia because Health Catalyst is not up and running fully for everyone. Is that what I'm understanding?
Yes. So we are the consistent data source that we were anticipating for this year throughout the entirety of the year was the Excelis Arcadia platform. We are still hoping to get back to that, but at this current moment in time, we have a data issue with some practices having their data not show up at all. And it's big enough to impact the network performance. So with that, we are looking at Health Catalyst where we're connected. We're still monitoring the Arcadia data, and we're working very closely with Excelis and Arcadia to try and address those issues in a timely fashion. I feel confident that they will be addressed. The timely fashion component of it is what we're still working on with those folks. So what we're I don't want to say pivoting towards, because we've been working towards this all year, but what we're trying to focus on right now is where we can training folks on the Health Catalyst and having them take a look at their overall practice performance.
So how would practices know which area they're falling into? And I ask only because several months ago we signed the quote that was sent to us for our system MedEnt to be able to connect to Health Catalyst, but we've not received any follow-up. So I mean, I've not created any reports within MedEnt that are being sent to you guys weekly like it was with Arcadia. So I think that I did sort of reach out a few months ago, and I don't even know who I reached out to, but I was told that, everything wasn't really up and running yet, and we would be contacted about, how to fully do all of that. So I believe our system is connected or has the ability to be connected to Health Catalyst, but I've not received any information about how to create any reports within our EMR that would be transmitted through that interface.
I can jump in here just very briefly. So Tanya, I think there's a couple things in your question there, and we can definitely talk more about this offline. I think that we are also going to have to get used to how we had to do things in Arcadia versus how we're going to be able to do things in Health Catalyst. And so some of those monthly or weekly reportings that you're used to, having to do won't necessarily be, required now that we're moving to Health Catalyst. By and large, we work directly with our EMR vendors who we have good relationships with, like MedEnt, to kind of automate and package the things that we needed to pull out of the EMRs. So there's not going to be that requirement per se. The next part of that is, I think your question about, so where do we stand, kind of ties into that. You know, we've got our MEDIC groups up and running. And so this next part, which is into quality dashboard training, is kind of what we're talking about. So your practice should be receiving or should have already received some information from Kevin about training. We're a smaller team that's doing that. So we're looking at availability. The goal really is to have those scheduled and or completed before the end of the month. So if you have not received information already, I'm sure it's, forthcoming, and we can connect offline and touch base with Kevin about the timing for your practice.
Yeah,
But
we're we are scheduled already, and thank you for that outreach. I just wanted to make sure that there wasn't, with Health Catalyst sort of being up and running, I wanted to make sure that I had not missed any communication about anything that we needed to do for the information to be transmitted. So I appreciate that. Everything you just said
Yeah.
answers my question.
it's a very fair and valid question to have, given, what we've had to kind of piece together over the years. So thank you for asking the question, because I'm sure others might have had a similar one.
Okay, and thank you, Elizabeth and Jana, for that. Jana, do you just want to continue on with the ACO REACH?
Sure, why not? So I will share my screen now. So if it lets me. So I am, oh dear, this is always so much fun, isn't it?
Dana, while you're getting ready to share, I'm going to steal a minute and just remind folks to put their name and practices in the chat if you haven't. I know there's quite a few people on phone numbers, and I may be good, but I'm not that good. So if you could just pop your name in, and I will get you on our list. Thank you.
Thanks,
Thank you, Molly. And I did find the button, so we are all good. Can everyone see that okay? Perfect. So as John kind of mentioned at the top of the hour, we are entering into an ACO REACH opportunity for the 2026 performance year. So it's not going to be applicable to all folks on the call, but I think it's important that as a network, we kind of know what's going on. So just wanted to take a couple minutes to share some information there. So about the ACO REACH in general, so we are partnering with an enablement company called Pearl Health, who's really, their partnership there is allowing us to enter this agreement for the 2026 performance year. They've had good success working with other groups and other clinically integrated network on the ACO REACH, MSSP models, etc. And so we, vetted them, we worked with them, and based on their experience and technological capabilities, we really do think that partnership there is going to allow us to be successful in this model. This is Medicare fee-for-service members only. This is not your entire commercial population. It's not any of your Medicare Advantage products. And so I think that's really important, because as we're thinking about scope and impact, it's important to remember that this is a very limited, population. It's very intentional. And so, we've done the work there. As I mentioned, it is not every single practice, every single provider, every single patient in AHP. That's because of who the population is. But also, as we started working through our activities with Pearl, we found that some sculpting to ensure, quality and financial success in the program was necessary. So we worked with executives, we worked with practice managers and clinical leaders at each of our groups to kind of determine, okay, does it make sense for you to enter this? Do you want to enter this for this year, as we, kind of look to success in that program? We landed on about 17 practices. That's across system employed providers, FQHCs and lookalikes, and then our private practices who will be included in the ACO REACH deal for next year. Before I get into kind of the details, and I'll finish up with key components, so it's a little sandwiched that way, but it's intentional. I want to talk about why we chose to do this. As LJ mentioned, it's important as you're talking about being beholden to another entity and their rules. Why are we doing this? And so I think as AHP's kind of wondered about that, it's really fallen into three things. We want to be able to improve patient care. So the model really does focus on improving health equity, access, and outcomes for those Medicare enrollees. and their beneficiaries. And it allows physicians to do that through kind of alternative payment methods, capitation. So really the focus is on patient care, and you get some revenue generation that way as well. This is in line with what we've typically strived to do through our value-based contracts. And so building upon that foundation is really important. This is a new way for AHP to drive gain sharing revenue and bring dollars to our practices and our providers. As John had alluded to as well at the top of the hour, we're really thinking about how we advance and how we, diversify and how we, innovate to continue to be successful. So this is another way for us to do that. And then really the experience in line with that. We want to be innovative, we want to be future thinking, and we want to be able to have success in some of these additional models that we've never partnered with. And so our agreement with Pearl, and I'll get into the details of it, we believe is going to allow us to gain the experience that we need to continue to be successful moving forward. So what's in it? So really it focuses on 3 pillars, which again are in line with the value-based care, kind of tenets that we have. So preventative screenings and annual visits, transitions of care, and complex care management. This is integrated into the work that we already deploy using our care management and population health approaches. So we really do think that this is a next step rather than a rebuild of the work that we do. Pearl does have a platform that reports what they call signals, which is supposed to trigger action to work with certain patients. We really wanted to be intentional and to reduce any burden that we're placing on the practices to kind of partner and be successful in this. So that platform is not going to be widely, broadly, accessible. We're going to really be intentional about who has to have access, and that's going to be part of how we're looking at the conversations and determining workflows versus, as an integrated model, et cetera. So we are going to be working with teams, but we do believe our care management organization is going to be the primary arm and the lever to do this work. And so as we continue these conversations with Pearl, we will determine if that makes sense for each of the practices and the locations and determine access for the platform as we go from there. These are really the measures, right? So this is largely claims driven. We're not looking for sophisticated data integrations, data sharing. And so again, how are we decreasing burden? How are we making sure that we can be successful without, adding another big thing to your list? So luckily the quality measures are primarily claims driven. There is this CAHPS component. Pearl Health takes that on as part of our arrangement and the work that we do here with them. And so we're really looking at a small set of measures for a small population that we believe is going to have great success. And so what are the key components and next steps? So this is a 1-year deal that we're entering into for 2026. We'll be evaluating throughout and looking at possibilities for continuing beyond the 2026 performance year. This is capitation for that population. So it's a monthly capitation for specific primary care codes. Other services in Medicare fee-for-service are continuing to be reimbursed. We do have a code set that's available if people have any questions about what that might look like. So it is not for all services that will be reimbursed through the capitation. There is an opportunity to earn advanced shared savings throughout the year, again, for those practices included. There's a shared savings component of this as we look at total cost of care for the population. And so there are some measures that we can hit throughout the year to advance those shared savings to you. And as we move through this, we'll obviously make the relevant groups aware of those. A big thing, and this is really important, is there's no downside risk for our network. So as AHP is entering this agreement, this is the first time we've entered into an ACO REACH agreement, and we really felt it was important to protect our network against any downside risk, as we've typically done on our value-based contracts. So our team, our executive team, worked really closely with Pearl on crafting what that language would look like over the summer and the terms of the agreement. So Pearl will be backstopping our risk. So if for any reason there are losses experienced, we are not at risk for that. So you are not at risk for that. We also wanted to kind of maintain network, revenue neutrality. So one of the concerns that was raised while we were doing this was, okay, what if capitation is not the same as what we would have been reimbursed by Medicare fee-for-service? What if it's lower? And so we've also arranged with Pearl to monthly true up. So if there's ever a situation where the Medicare fee-for-service reimbursement is higher than the capitation rate is, they look at that monthly and true it up and make a payment to you all. So really what we're looking at as next steps is, now that we've kind of gotten through those initial CMS deadlines and the contracting period, looking to our next conversations with Pearl Health to determine, okay, where do we want to be successful beginning January 1? And so some of those conversations I believe are happening as soon as this week. And so we will begin to, trickle that information out as we, the internal team become more aware and plan for that. So really beyond that, we're going to be turning to the included providers and practices to say, okay, where does it make sense for us to integrate? Are we, does your team have the resources already in place? Some already have AHP care management, pharmacy, et cetera, integrated into the practice. And so really we'll just be, pushing this out through those methods. For some who employ their own care management, employees, are we going to be integrating with them? Do you think it's best that they own the process? And so we're going to start to have some of those conversations as we, become more aware and acquainted with the program. But I will tell you, our team has been working very, very, very diligently on this over the summer. And I came back and hit the ground running with them just as well. And so we've had a really, it's a lot of stuff for us to get up to speed with, but we are doing well. And I think we're going to be successful in this, and that's the whole. I will pause there to ask for questions. I will also open it to any of the AHP folks who want to add some comments around this. No one? Did I do that well?
Hey, Jana, this is John. So yes, you did a phenomenal job. So thank you. I just want to reiterate, what Jana said. Our team is working to put together a formal implementation process. And that process will engage, those of you that are participating in this program with us. It'll also engage our clinically integrated network at large. And, it is a key initiative because I think, as we all are aware, CMS is moving to more and more models like this. We don't know what they will look like in the future, but what we do know is that these models are not going away. And what we're seeing happening with CMS is that a lot of these models are becoming mandatory in the future as well. So where this year we have the opportunity to not participate, in the future, it may not be a choice. So this is going to give us a really good opportunity to learn, to innovate together, and be prepared for whatever changes CMS, CMMI throw at us going forward.
Thank you, John. Were there any questions in the chat? Let's see.
Not seeing any questions in the chat.
Okay. Right. Well, with that, I'll move on and I'll keep talking. We are entering our favorite time of year. It's roster season, folks. And so we will be expecting our first set of draft rosters from our payers here in the next month or so. And so, we've stacked our membership and board committees through the end of the year to make sure we're capturing as many folks as we can. But I like to take the September meeting to really remind people of what are the criteria you're adding people, you're terming people, so that we're in the best shape possible to ensure accuracy when we deliver those rosters. And so if someone is leaving your practice, but this really applies to everything, rule of thumb, if you would tell the insurers, please tell AHP. We are looking at ways to, push more information out to folks so that we can, we're not the thing that you have to remember. But for now, we really do depend on your practices and your teams to keep us informed of how providers are, flowing in and out of your practices. So we do need the provider's last day at the practice, and if you're able to, any information on their future plans. So, if someone is finishing a residency and is moving to another state, or they've decided, retirement is looking great right now. It's important for us to have any of those details because it does impact how we include them in rosters or not include them. It also impacts any payments, so clinical integration dollars, gain sharing, all of that is tied to when we're alerted and what your provider is doing next. So it really is important for us to understand that. So I'll pause on that note before I jump ahead. I give these slides every year, and so I feel like I'm always ahead of them. If someone's joining your practice, let us know as soon as you have a start date. That doesn't necessarily mean that that's the date that they're going to be effective, but we do like to know ahead of time so that if we do have upcoming membership committees, we can plan for that. If we know it's going to be a tight turnaround, we also want to confirm with your practice when that date arrives. They did also start. Unfortunately, we all know that sometimes that day arrives and plans change, but this gives us the opportunity to plan ahead. This is important for physicians and your APPs. As you know, a couple years ago, AHP, New York State allowed APPs to be full practice with their licensure. So we now have APPs who panel patients. And to prevent the loss of attribution to the APP and to your practices, it's critically important that we know who they are so that we can monitor that and include them in submission. By nature, they are participating in contracts. It's just we are now utilizing them differently as a network. So we want to make sure that we have accurate information about who is at the practices. We do not bring your APPs to membership, i.e., formally enroll them in AHP until we know that there's enough attribution to cover their capital contribution, which is a one-time fee of $300. We net that out of the first payment. And so, we're not going to charge you, $300 if you have an APP who may never reach that amount and you may never see clinical integration dollars for. They do have to be enrolled in membership and board, just like our other providers. And so I just have a short list here of what we need. So first, last name, NPI, the start date, and an email address. I know sometimes the email addresses are not active before they actually start, but if you do have them, you're supplying an advanced start date. It's helpful because then when we go to turn them on and say, yes, they're fully participating now after board, and, we don't have to collect that piece of information, and they are able to start receiving kind of our clinical newsletters as soon as possible. We do have membership and board about 6 times a year. And so there's lots of opportunity throughout the year to add providers. And so we really do ask for you to send those timely so that we can go ahead and do that. Continued. This is the next part of that. Because we also have, this is not just in service of health plan members for which we can add providers throughout the year to service those plans. This is also for our value-based contracts. So when we're talking about rosters, it's in service of this. We are limited by our payers for when we can, the specific entry points for adding providers to a roster. Excellus and Monroe Plan have a one-time once per year where we can add providers. So if we miss those cutoffs in the fall, they are missing an entire year, and you're missing an entire year of value-based care contract participation. So we want to avoid that whenever possible. MVP does allow us to add providers twice a year at the top of the year 1/1 and then mid-year 7/1. So again, I'll talk about the entry points and notification periods, but it's important that you let us know ahead of time. We are adding people at the time we are alerted to them joining your practice, not at the time that they joined your practice. So if you have someone who started in February and you don't tell us for some reason until May or June that they've joined, we might be missing them. And so it is very important that as soon as you have someone with a start date, you do let us know. Providers have to be participating in all of our contracts that they're eligible for to be included in that reward plan. So if we miss the Excelis entry point, but we've made the MVP, you might receive MVP clinical integration dollars for the year, but the PCP reward plan eligible, they will not be PCP reward plan eligible for that current year. So what are the actual timelines then? So the way that we do this is from the top of the year, so January 1st through May 14th. If you alert us of a provider joining your practice during this period, they are included 7/1 for the MVP contract, and for Monroe Plan and Excelis 1/1 of the upcoming year. So for example, on 3/1, you told us that Dr. Smith joined the practice. Their participation for MVP begins with the 7/1 2025 start date. They will not go on contract for Excelis or Monroe Plan until 1/1/2026, which is again a full calendar year away. And that is the first year that they will be eligible for participation in the PCP reward plan. May 15th through October 14th, which is the time frame that we're in right now. Anyone who is we're aware of at this moment becomes eligible for Excelis MVP Monroe Plan at the beginning of 2026. So they would be eligible for 2026's PCP reward plan as well. Once we move beyond October 14th and we're looking at the end of the year, we have now, theoretically submitted our rosters to our payers. And anyone who we're notified of joining a practice during this time period does miss the cutoffs. They'll be added for 7/1 of 2026 if we're looking at 2025 for MVP. And then Excelis and Monroe Plan, they would not be on contract until 1/1/2027. And so that would be the first year that they're, eligible for participation in the reward plan. So again, it's really important that we have timely notification. We have tried to piece together, onesie twosies in those final days, but it does really generate, some, issues and downstream effects if we're not, really, really meticulous. And so we've done this to make it easier and clearer for you, and to ensure that we have accurate processes around that. So if you are now looking at me like, oh, well, Jana, I think I have a provider who's going to be joining in November, but I'm not sure. Please provide any future start dates that you have. We can submit them to the roster, and if they fall off, they've fallen off, and that's well and fine. But we will not be able to submit them after the fact. So if you have a start date, we can plan ahead for that. We can confirm with you that they did in fact start, but you can feel free to share that with myself, with Molly, with Selena, and we will go ahead and include them where we can, right? So, we will always confirm that they've started, but for the purpose of rosters, if you have folks that are coming to you in the next couple months, please make us aware. Okay, I'll stop sharing. I will pause there. I will ask for questions, comments, concerns. I had a professor in college who would say gripes, grievances, but I don't want to open us to too many of those. Okay.
All right. Thank you, Jana.
You're welcome.
I am going to share my screen. Everyone see my screen okay? Wonderful. Thank you. So we are winding down with our time together today. So just want to open it up if there are any questions or things that folks would like to discuss while we are here and have some of our AHP subject matter experts on the line. Not seeing any. This is also a really good opportunity to mention that if you think of something that you would like us to address or explain further in any future meetings, certainly reach out to us. We're happy to meet the needs of what you're looking for. So just let us know if you have a topic in mind that you'd like to chat about a little bit more.
And this is also a good reminder because I see people starting to drop. If you have not entered your name into the chat, you want your practice to get your citizenship components for 2025, please enter your name and practice into the chat box.
Thank you, Jana.
Yes.
So we only have one meeting left for 2025. I can't even believe it. Our last practice manager meeting for 2025 is December 10th. At this noon time frame, we will certainly send out reminders as it gets a little bit closer. And yes, we are in AHP. We are in the AHP network. So what does that mean for your patients? So we ask that you refer your patients to AHP specialists when possible, admit patients to AHP hospitals when possible, and send patients to AHP imaging and labs whenever possible. Also, for your practice, monitor the provider engagement report. That training is coming up for your practices. So as that develops, certainly start getting in the habit of checking that and reviewing that. Attend these meetings and engage with communications that we send out, our network news and our pharmacy pearls, and then just help providers to connect to other AHP resources. We are always happy to take calls or emails and try and work people through something that they're going through. So reach out to us. And here are just some contacts here at AHP. You don't have to write all of this down. I will be sending a follow-up to this meeting. Included will be the slides and a link to our YouTube channel, which has a recording of today's meeting. And then here are contacts for some of our partner programs, such as Medline and Atlantic Health. Is there any other questions before we sign off? All right, I'm not seeing any. Everyone have a wonderful day, and we will see you in December.